I would now like to introduce Alexa Eggleston. Alexa leads implementation of the Conrad N. Hilton Foundation's Youth Substance Use Prevention and Early Intervention Initiative. Alexa, if you are ready, I can hand things over to you.
Okay, great. Thank you, Jess. As Jess said, my name is Alexa Eggleston, and I'm the Senior Program Officer at the Conrad Hilton Foundation, leading the strategic initiative that the webinar today is related to. I want to thank, of course, Jess and everyone on the phone today for joining us and to listen in and have really a conversation about the great work that is happening across the country to advance more screening and early intervention services for young people. The work that is being generated through the strategic initiative is really designed to hit on a couple of key themes. First and foremost, that substance use in young people should be addressed as a health risk behavior, just as we address concerns around nutrition and sleeping, mental health, sexual behavior. It is also really designed to help practitioners, families, our communities better understand the harmful impact of early use. We know that 90% of people who develop a substance use disorder later in life that starts with use during adolescence, and so we need to be doing much more to intervene earlier with young people that have started to use alcohol and drugs, and really intervene to address whatever is going on in their life before crisis hits. The focus of that work has really started with the screening, brief intervention, and referral to treatment model that you're going to hear more about today. And we have been fortunate in particular to partner with the American Academy of Pediatrics over the past couple of years to really develop more learning and evidence about what this model looks like when adapted for pediatric practices and to serve an adolescent population. And certainly the leadership that AAP has shown in terms of the initial policy guidance several years ago and the revised statements is, I think receives much credit for really informing the work that we're all doing. And so I'm thrilled to be able to highlight that work and the guidance that AAP has developed. So with that, I'm going to quickly introduce our presenters so we can dive right into the content. Dr. Janet Williams is a tenured professor of pediatrics at the University of Texas School of Medicine at San Antonio. She has been a School of Medicine faculty member for 30 years and is a recognized expert, has recognized expertise in child and adolescent growth and development, substance use education, and patient care communication. She also recently completed 10 years of service on AAP's Committee on Substance Abuse, and I think gets much of the credit, along with Dr. Sharon Levy and her other colleagues, for the research and policy statements and other materials that have been developed relating to the intersection of substance use and young people. Dr. Rob Dudley is a pediatrician at a federally qualified health center in Connecticut. He has championed for many years quality improvement initiatives related to substance use screening, is a lead for the Connecticut chapter, which you'll hear more about today, and has really a range of experience thinking about how substance use screening intersects with other important screenings that we know young people need, whether it's depression, immunizations, asthma, STD, etc. In addition to serving as the medical director at the Federally Qualified Health Center, he is also an assistant clinical professor at the University of Connecticut School of Medicine. And with that, I'm going to turn it over to Dr. Williams.
Thank you. Next slide, please. It's really terrific to be here to explain why SBIRT, or Screening, Brief Intervention, and Referral to Treatment, is essential to adolescent health and essential for those providing health care to children and adolescents need to engage in this behavior. Next slide, please.
Just
Okay.
give me 1 second here. Hold on, I'm sorry.
Okay, I'll just keep talking a little bit about SBIRT. It's an abbreviation, an acronym for screening, brief intervention, and referral to treatment, because that's quite a mouthful to say all at once. But it is a comprehensive and integrated approach, systematic, it's evidence-based. There's quite a bit of research on it now, starting with adult medicine, but into pediatric and adolescent medicine, that this approach is really an excellent way to identify people at risk and people already with problems. So you're looking at the continuum of no use, so abstinence, to use with problems, addiction, and also how to then proceed in getting access to care, early intervention, and prevention. This is really a public health approach to care. And this is the same type of screening and approach, early intervention, and access to care that's done for many other issues. But when people start talking about substance use, it becomes rather sensitive. Next slide, please. Yes, so SBIRT is also an algorithm. So it's an acronym, an approach, and an algorithm. And you can see you ask one simple pre-screening question, yes or no, are they using? And if they're not using, you go on to what would be a natural, encouraging response from a pediatrician, a leader, someone that the child, adolescent, we hope will think of as a positive authority figure. And you say something wonderful like, gosh, you've made some great choices about your health in not using tobacco or in not drinking alcohol at your age. I hope you keep making those smart choices. There's your reinforcement for low-risk behavior. So as you get a positive, you use a tool, a brief tool that allows you to figure out they're using, and at lower risk, I'll address that. They're using at medium risk, I'll briefly intervene on that. I'll bring the right next step approach. Or they're using and at tremendous risk and or already have a substance use disorder or addiction, in other words, and I need to open access to full treatment. Next slide, please. So why SBIRT? Why are we talking about this? What's so important about it? What's important is the extent of the problem. Because at least some of the substances used by adults are, quote, legal, it's often not in the public view the tremendous cost to health and welfare and society in general that alcohol, tobacco use, and other drug use or misuse of prescription drugs causes. It's a huge economic burden to society. So alcohol misuse costs over $250 billion a year, most of that related to binge drinking. Smoking is even more than that. Smoking-related illness, we've known for many years, it's the #1 preventable cause of morbidity and mortality in the U.S. and responsible for over $300 billion a year. So alcohol is the 4th leading cause of preventable death, and since as a pediatrician I have to think about use in the home, use by parents, and what's that doing to the child's health, directly or indirectly. So 10% of children have a parent with an alcohol use problem. That's really significant. That doesn't talk about all the other problems with, let's say, binge drinking in the home. So it needs to be thought of that we're doing SBIRT because we're not just looking at the individual's health directly from use, but we're also looking at the indirect risks that are caused to the family, legal problems, social problems, a much broader extent. And amazingly, alcohol, drug, and even tobacco use often go undetected. That's even in adults. Why? Oftentimes, nobody asks about it. Next slide. So these substances are used by adolescents too, and children. Alcohol, tobacco, marijuana are the top three. In some areas, inhalants rival marijuana, and certainly prescription drug misuse is right up there, rivaling marijuana, although marijuana has its own reasons for becoming more popular. What we can see are data from the Monitoring the Future study. This study has been done nationally for over 30 years on an annual basis, a broad cross-section of adolescents across the country in rural, urban, public schools, private schools, you name it, in order to get a great, reliable cross-section. They added many years back 8th graders and 10th graders to the 12th graders so that they can see trends of what's happening over time. And then a segment of the 12th graders are followed into adulthood. And those studies are easily accessible online through just Google Monitoring the Future. So what we can see is that alcohol use is really common. And if you think about, I just put down some of the data from this last year's study, 2015. How many were drunk at least once? That's pretty amazing, almost half of 12th graders. 17%, so you're getting close to 1 out of 5 in the last 2 weeks before this survey were engaged in binge drinking. That's pretty incredible and horrifying from my perspective. We know that kids are using a lot of e-cigarettes, and as a matter of fact, they're using more than regular cigarettes. They thought the rates of regular cigarette use was coming down until they looked at e-cigarettes. And there are several studies now that show that they're not using e-cigarettes to stop their other tobacco use. They're using e-cigarettes to experiment, or in some cases to put other things in that chamber, not just tobacco. And 6% of 12th graders said they are using daily marijuana daily, and 21% said they'd used it in the past month. Next, please. Additional data about why is this a problem. We can see that the prevalence of use of any illicit drug is pretty high in 8th, 10th, and 12th graders. And yes, okay, any illicit drug does include marijuana, but if you take that out, it's still pretty high. So 1 out of 5 12th graders said they're using any illicit drug in the last year. Prescription drug misuse, like I said, is really important and rising in prevalence, or at least stable. And 13% of 12th graders said they had done that. Mostly it's ADHD stimulants, but could be prescription pain relievers misused, and many come from the home. Next. So why are we talking about this? Well, in adult population, only 1 in 6 ever talk to their doctor about their drinking, and certainly about their other substance use. Now, most of the time, it's gotten common, even in pediatrics, to ask about tobacco use. In pediatrics, we're often asking about exposure in the home, so we can try to decrease their number of respiratory tract infections and asthma type outbreaks. So, but now it's time really for the healthcare team somewhere in that team in the office to stop saying, well, somebody else will ask, or these are legal in the adult case or older adolescents. So overcome that stigma. Really address the topic, because I can tell you adolescents are expecting you to address it confidentially, personally with them, not with the parent there, and to normalize your routine so that they know to expect this. Just like they're going to anticipate you ask about tobacco use, they're going to anticipate that you ask about alcohol and other drug use. Next. The other thing is parents and adults always underestimate the amount of use, the type of substances that are used, how they get them, where they get them, how early they use them, and what the nature and extent of risks and consequences are. It's every time they do a poll of parents and adults about adolescents or children, they're stunned at the naivete or denial of adults. So someone has to ask, and that's you. Next. So a little bit about adolescence. What's going on there? What makes adolescents more at risk? And why are we talking about this and think it's critical in this time period? It's because of the vast amount of brain development that is occurring and still has yet to occur. It's really a critical period of setting their adult behavior patterns and capabilities. So because of this neurodevelopment that's going on, myelinization, connectivity, and maturity in the brain, it's a time of vulnerability. It's a time for opportunity also. This opportunity, SBIRT opportunity, it's a time for risk-taking and consequences, including how what they do in adolescence dramatically affects their risk of addiction as an adult. Next. Next. So Professor Sylvester said it should come as no surprise to discover that the how to do it capabilities mature before the whether to do it capabilities. So many adolescents can successfully do things that they shouldn't. Next. So what we know about adolescence is here's what's happening during that time, developmentally and then neurodevelopmentally. They're trying to figure out who they are, their self-identity, their sexual identity, their vocational identity. Who am I? What do I mean? What am I going to do? And emancipation, that I am an individual myself and I'm not what my family necessarily says I am or going to be, or someone else, the school or society. Those are the goals. Next. And an important part on that slide too was adolescence isn't age 16 and 15 only. It goes from generally about age 12 well into the 20s, to the mid to late 20s should be considered adolescence in terms of neurodevelopment and general personal development and maturation. So how is it that adolescents achieve these goals of identity and emancipation? Well, they do it through behavioral experimentation, testing authority, rejecting parental values, and that whole struggle for independence and looking for definition of self. And anyone who is a parent or has worked with children and adolescents, they've all experienced this rejection of authority and parental values and experimentation. Next. Next. So because of that, I say what's out there to try to use these tools and get to those goals? Well, nowadays, alcohol, tobacco, and other drug use is readily available. It's certainly not an unhealthy choice. I mean, it's certainly an unhealthy choice. But that's what, because it's available, it's out there and often selected as the means to try to fulfill these developmental processes and transition to autonomy. Next. So what's happening in the brain? Well, we do know that different brain areas mature at different speeds. Parts of the brain, when they approach adolescence, are pretty much the same. You know, your brainstem is pretty much the same. And your cerebellum, your balance, your coordination, that kind of thing. It's gotten to a certain point and it's maturing way faster than what's happening in the cerebral hemispheres, especially with the frontal lobes. So it's well known now from lots of studies of function, process, metabolism, imaging, that they can follow the myelination and brain growth and brain area usage as you're doing tasks, like with functional MRIs. And it shows what's happening, and the frontal lobe is last. Next. So what does that mean for the frontal lobe to be last? Well, it means if it's immature, you really can't inhibit your responses, control your impulses quite as well as you could as an adult, a fully mature adult. You've got less abstract thinking, so you can't really anticipate consequences of actions, organize, strategize, problem solve, multitask. You're really still grappling with how does this look and what does that mean? That cognitive flexibility and insight into problems in front of you, your judgment, and how you regulate your emotions. The emotional centers of the brain are more mature and more readily available to the adolescent, let's say, as far as expression, than controlling those impulses and thinking through the consequences. So there's more risk-taking and more impulsivity, and your decisions are based on, emotion or reward, immediate feedback, and really not on organization and planning. Next. So why are adolescents more vulnerable to developing a substance use problem? Next. It really has to do with this added vulnerability. So because of this neurodevelopmental change and propensity for risk-taking, they're more susceptible to actually taking risk and risk-related injuries. Many of substances are neurotoxins, and in rapidly growing cells of any type are usually where toxins hit. So when the brain is still developing, that's where toxins hit. And if there are other health issues, other complexities, it does increase or change, probably diminish the threshold of vulnerability and complicates consequences. So most of the time, alcohol drug use consequences are not due to addiction, and it's rather the thought that every risk, every substance use confers risk of some sort. And so that's why SBIRT is looking at not the tip of the iceberg only of who's addicted. We're trying to do early intervention and diminish or negate that risk. Next. Something that I think is particularly scary is there is growing evidence that exposure, particularly repeated exposure to drugs during adolescence, because of this plasticity of the brain formation and processes, there may actually be permanent change in the brain structure, chemistry, function, including addiction risk. And we do know that the earlier substances are used, the much higher rate of risk for addiction is predicted. It's a very close correlation. So what do we know about the benefits of SBIRT? We know that substance use disorders, in other words addiction, are preventable. We know that risk is preventable. We know that we can identify disorders. We know that early intervention improves outcome. And we also know just from a motivation for change or behavior change operations and tools that people of all ages are interested in knowing about their health and how to change their health risks. And parents are particularly interested in their child or teen's health, and they'll do things to help their health that they won't do for themselves. People are more open to change than expected, and pediatricians can make a difference. So next. There are just a few recommendations from the policy statement that I'd like to review. The American Academy of Pediatrics recommends that pediatricians do gain the skills they need to use comprehensive SBIRT practices. That health insurance providers promote and reimburse for SBIRT as part of the medical home health maintenance. That research be increased in regard to what are effective brief intervention and treatment types that are applicable and successful in adolescents. More highlights from the clinical report. Of course, abstinence is what's recommended for adolescents because of their neurodevelopmental vulnerability. Confidential screening is always recommended for any type of conversations with adolescents as part of their routine health care, and screening should occur at least annually for their every health maintenance visit, but of course when there are other types of visits where this might seem pertinent, that should occur then also. Next. And lastly, there are validated screening tools, and those should be used, not just a clinician's gestalt, which is known not to be very sensitive to detecting substance use and substance use problems. And brief intervention skills are known to encourage behavior change, and those skills should be learned and used also. So it's very important to work with the patient, work with the family in order to find the best referral options for addiction, for substance use disorders. And the continuity of primary care also is very important during treatment and after treatment, so the patient and family know that they still have their medical home supporting them. Thank you.
Hi, folks. So, as was mentioned, I'm a primary care pediatrician in an urban setting in Middle Connecticut. For the past year, Connecticut practices in Connecticut, Georgia, and Utah have been participating in an AAP program to actually implement screening in primary care settings and to actually put SBIRT into practice. And I want to really thank the AAP and also the Conrad and Hilton Foundation for making that program possible, and also for all the wonderful things it's been bringing to pediatricians and kids across the states. Next slide, please. So when you think about it, primary care is a logical place to look for these disorders. We have longitudinal relationships with families and with teens. We're really centered around the family, and opportunities are abound for doing the anticipatory guidance that are part of SBIRT. It's also important to think, though, about sort of, as Dr. Williams was talking, about the way teens are developing. They're getting a sense of autonomy, they're getting a sense of independence. So having that long-term relationship really allows primary care providers to sort of help parents and teens navigate that system from real dependence and parents making decisions for you to having issues around confidentiality and being able to choose to keep certain information confidential from your parents, really taking on the role as decision makers when they're adults. And SBIRT is a perfect sort of like mini world to play with those issues as kids navigate adolescence. There's opportunities to intervene early, and we have experience with coordinating with specialists, with tracking referrals, and also with dealing with issues in a chronic care model. AP recommendations are to screen for behavioral assessments, depression screening, and alcohol and substance use at every well-child visit from 11 to 21, but also, as Dr. Williams mentioned, at appropriate acute care visits. So when I see teens who appear to have a very flat affect, I whip out that PHQ-9 regardless of how recently I've done it and reassess. If I think that a child is having some sorts of problems dropping grades at school, I might whip out a couple of different screens, both the PHQ-9 and my SBIRT, just to see what's going on. Next slide, please. So some things if you're starting to think about implementing a screening that are real important. Obviously, it's important to be able to support youth with services who do screen positive. As Dr. Williams mentioned, using a validated screening tool can make a huge difference. I've seen over and over again as we've implemented developmental screening, maternal depression screening in adolescents, and anxiety screenings. Oh, back one, please. That using a validated screening tool can actually increase up to 30% the number of children that we are referring. It's very important to maintain a chronic disease registration and tracking system so that when you have kids that are screening positive, you can follow up and make sure that they actually are doing what you've asked and that kids haven't fallen through the system. It's important also to learn about coding so that you can be paid appropriately for doing screens. Many of these screens in many states now are being reimbursed and can increase providers, help to reimburse them for the time that they're spending. Finally, it's important to establish an office crisis plan for folks who might be suicidal or dangerously impaired so that you don't have to come up at the last moment be confronted with a child who needs emergency services. Next slide, please. Remember that algorithm. Screening is not just a one-step process. It's sort of an ongoing process that you enter into with kids even before they're 11 years old. A negative screen doesn't mean that you're not going to be doing something. You're going to be reinforcing that positive behavior and reassessing on a regular basis. If you do have kids that screen positive for use, you're going to be doing an assessment, looking at the level of use and if they're having an actual disorder, and helping them, if they do have a disorder, get referred for treatment and discuss things with parents. Next slide. It's something that we've found as we've gone through this QI process that's really important, is that it's very important for providers to have time with adolescents in the room without their parents. It's also important for teens to be doing these screens when their parents aren't there. Back, please. When we initially started using the SBIRT process in our practice, we would let kids do it with their parents in the room, and we'd come in and find parents filling out the screens for the kids, parents reading the kids' screens, parents looking at the teens and saying, oh, this isn't right. I know this isn't right. So very, very important that they do that in privacy. You know, what we currently do with our process is parents receive a paper that sort of explains the process. We're having teens brought into the room to get prepped for their physicals, their blood work. They're handed their PHQ-9 and their craft screen, which is our SBIRT screen, and they fill those out, and then I come in and spend a little time with them going over the screening results and talking to them about concerns that they have before we bring the parents in. It actually improves our workflow. We've done some time studies that show that our visits are actually shorter doing it that way because there's not the moving of the parent in and out of the room when they start off the visit. So it can be very efficiently done, and I certainly would encourage folks to look at using quality improvement methods if they're putting in a screen, try out different things to see what works best for them. And the other good point about having some private time with the teens is if a problem is discovered, there's time to discuss with the patient about how that information is going to be disclosed. Next slide. So remember, SBIRT is a mnemonic for screening, brief intervention, and referral to treatment. We're going to be talking a little bit now about the individual elements of SBIRTs and then sort of looking at how they play out with an actual standardized screen. The screening casts a wide net. It's really meant to apply to everyone in the target group, meaning teenagers. It's not that yes or no answer. Each level of use requires a sort of response. Remember, kids do stupid things, and substances help them to do stupid things more stupidly. Even one-time use can lead to injury, violence, or risky sexual behaviors. Next slide. It's really about finding out where kids are on that spectrum. Next slide. So screening assesses a person's substance use and identifies the right level of treatment. It's quick and it's simple, and the goal of SBIRT is to make it a routine part of healthcare. What we find when we've been doing this for a year now is kids come in and they expect to get those questions. They expect to have that discussion. I've also found that starting even as early as 8 or 9 years old, talking to parents about do they have those conversations with their children. You know, the G-rated version of I don't want you to smoke, I don't want you to do drugs, I want you to be sexually responsible, actually is a very good way to sort of open the door to having conversations in an ongoing way with families. Next slide, please. So some standardized tools that are out there. If you look at the AAP policy on SBIRT, there's a whole host of them. These are some ones that many people use. The screening to brief intervention, the brief screen for tobacco, alcohol, and other drugs, and then the alcohol screening and brief intervention for youth are all standardized validated screens. Assessments include the CRAFT screen, which is for car, relax, alone, friends, family, forget, and trouble. The DAST-A, which is the drug abuse screening test, adolescent version, and the alcohol use disorders identification test, which is the audit. And actually our adult practice here uses the audit-C as their screen. Next slide. So if a patient does screen positive, the next step is to provide some brief intervention. You know, you really want to have an outcome responsive dialogue, and once again, knowing where they're on that screen really helps. Sorry. Next slide. So you can have children who go from no use or no substance use disorder on the left-hand side all the way over to those with a severe SUD. You're going to sort of tailor the interventions that you provide based on how the child screens or the teen screens. You're going to provide positive reinforcement to those that have no use. You're going to give some brief advice to those who don't have a substance use disorder but have tried alcohol or smoking or marijuana. And then children with more significant use, mild or moderate SUDs, monthly use, or those with severe SUDs, you're going to start having those motivational interventions. You're going to be assessing for any problems that they have. You're going to be advising them to quit and also making a plan that you're going to follow up with future appointments with. For those with the more severe use, you're probably also going to be referring them to treatment and breaking confidentiality. Having plans about how those things are is actually pretty simple to put in place, as we're going to see in the slides ahead. Next slide, please. So remember, it's a spectrum from abstinence to severe use disorders. There's some really great literature out there in terms of what sort of goals you're going to be looking at for kids. There's also some wonderful scripts, as we'll see, especially with the CRAFT screen that we're going to be going over in a minute. Next slide, please. And remember, getting that care in a medical home or in a primary setting is so important. That doesn't mean that screening can't take place in other settings. Part of our PIAASU project is kids getting screened at school-based health centers. We also have the potential in our practice to be starting screens in our dental practice or with our behaviorists, with referral back to the primary care provider to help arrange further assessment and treatment. Next slide, please. So remember motivational interviewing, which really isn't behavioral intervention, but the spirit of it sort of permeates the way that you're going to be doing brief interventions. It's really all about the language of change. It's designed to strengthen personal motivation to attain specific goals by eliciting the patient's reasons for change in an atmosphere that's accepting and compassionate. Next slide. And it's based on that idea that humans really tend to resist being coerced and told what to do. And I think I see this over and over again in asthma care, diabetes care, eczema care. If you try to tell someone what they have to do, they will fuck you all the way. It's much more important to engage people actively in changes that they're willing to make. And it's also important to acknowledge their freedom not to make a change and what the consequences of that will be. Next slide, please. A skilled interviewer asks the person where they want to go, listens and respects to what the person wants to do, and then also informs the person about options that are available to achieve their goals and what makes sense to them. Next slide. It's using sort of empathy. You develop discrepancies. You listen to sort of facilitate what elements of values patients have versus what their behaviors are exhibiting. You really have to roll with the resistance. Certainly I've had plenty of teens who've said, I don't want to give up my marijuana. It makes me happy. You know, and they're also severely depressed and sort of self-medicating. So rolling with that resistance, offering alternatives, meeting them where they're willing to go. And then you really want to support them. It's all about sort of helping them to understand. They may not be willing to engage today. Next week or in a couple of weeks, if you planted that seed, they might be willing to engage and enter into treatment. Next slide. And so finally, for those willing to enter treatment, to refer them, it's really important that you have good resources available and good lines of communications established. The effectiveness of the referral process is really a strong measure of how your SBIRT is working. People who are engaging either in brief treatment, and in the practice that I'm in at QHC, we have integrated behavioral health. So for children with those lower level substance use disorders or often comorbid conditions, we're able to get them in with therapists within the practice. How successfully you can communicate and make those handoffs and then follow up the treatment really is where it's all at, so that they don't end up falling into a more significant substance use disorder. And then if a child is in a real critical place where they need intervention quickly, having an identified resource who you can reach out to is key. In Connecticut, we were very fortunate to have, as part of our PIAASU project, 3 child and adolescent psychiatrists, 2 of whom have a specialization in substance use, who were very open to letting us go through their organization's referral line and get access for kids quickly. And actually, I have a child last week who started an outpatient treatment program for narcotics, which we were able to assess. It's important to have those phone numbers, be able to put them in the kids' hands and have them call, or the parents call right then and there with you, and then be able to follow up with them soon. Finally, remember, it's a process and you have to roll with that resistance. Some folks who are high risk are not going to be willing to engage in treatment. Some parents may be resistant to hearing the message that their children have a problem. It's incredibly important to be able to offer some level of treatment, whether that's follow up with you in a couple of weeks to reassess, whether it's engaging them in a lower level of treatment, which might not be your ideal, but is what they're willing to engage in. You can often find that once the kids get in and start thinking about things and talking with the therapist, that they're able to progress. Next slide, please. And then know your resources, vet your resources. I've included some links throughout the talk for folks. And then finally, if you want to take the final step, be open to getting your buprenorphine waiver to think about helping teens who actually have developed an opiate addiction. Next slide. So with screening, just talking a little bit about them. Some common screens, the screen to brief intervention, which was developed at the Children's Hospital in Boston. It's a brief screen, which is if negative, you do an assessment using the CRAFT screen. Sort of a disadvantage there that my behaviorist friends like to note is that you lose that car question, which I think is very important. Next screen, please. So if you look at the screen, this is actually pretty much the whole thing. You can see they fit nicely on one page. They're very brief, pretty simple, and I think very easy for patients to do. The one thing that I do notice is as the kids go through the screens and complete them, they often will do the 3 initial CRAFT screens and then go right on to the screening questions and then go right on to the assessment part of the CRAFT. Next screen, please. Once again, you're going to sort of, depending on your S2BI results and the subsequent CRAFT screen, stratify the kids as no risk, low risk, moderate risk, or high risk. Next screen. And then in our office, we're actually just doing the CRAFT screen, which is an initial interview with my medical assistant who hands them the questionnaire and goes over filling it out. It's a simple sort of 3-question screen. If they answer no to all of the questions, they answer a CAR screen, which asks about riding with people who are high or intoxicated. If they answer yes to any of the initial 3 screens, they go on to the assessment portion of the craft screen, which is the 6 questions. Next screen. And the next screen. And so this is the actual craft screen, which you saw a little bit attached to the S2BI. Those 3 initial questions: in the last 12 months, did you drink any alcohol more than a few sips, smoke, vape, or eat any kind of marijuana, use anything else to get high? And if they answer yes to any of those questions, they go down and do the 6 assessment screens. So going back to what Dr. Williams was talking about, the first 3 questions are the screening part. The next 6 questions are an assessment that helps you to stratify their risk and determine what level of advice, brief intervention, or referral you're going to be doing. Next slide, please. And then that's just another close-up of the craft. And then another, next slide, please. Yeah. So once you've stratified the patient, this is sort of like the complete response. So next slide, please. So if they're low risk and have a negative screen, you're going to praise them and encourage them to not do drugs or alcohol, and say you've been doing a great job. Next screen. If they answer yes to any, you're going to administer the craft. Next screen. If they answer yes to the CAR screener, obviously that's a big risk. I mean, one of the #1 ways that teens are injured and die are in car accidents. You really want to advise them, don't ever ride with a driver who's ever had even a single drink or been doing any substances, because it's not safe for them to be driving. And you offer them a contract for life. And next screen, please, which is here. You can find it online. It's actually pretty powerful. Kids, it's one of those things where you ask kids to sign, and I like to say it puts a little cognitive bump in there doing the dangerous behavior again. Next screen, please. Offer some brief advice if they're low risk. I recommend that you stop drinking or smoking, and now is the best time. Alcohol kills and drugs kill brain cells and can make you do stupid things that you're going to regret. As I said, a lot of electronic health records, it's possible to program these screens and the little blurbs, which, I don't think people necessarily want to read verbatim, but if you're new at it, it doesn't hurt to just sort of read them to start off with and then say, so what do you think about that? Next screen, please. Next slide, please. So the craft greater than 2, you want to do a little bit more digging. Tell me about your alcohol or substance abuse. Has it caused you any problems? Have you tried to quit, and why? And once again, those questions lead you into that motivational interviewing approach. Why have you tried to quit? Oh, because I'm failing out of school. Oh, do you think that has anything to do with your substance abuse? Yes. Would you be interested in trying to get some help to cut back? Really important, once again, nail them down on some commitments, put it in writing if you have to, repeat frequently, and then make a plan for follow-up. And the follow-up is key, because even if you can't get them to engage that day in services or in making a decision to cut back, most kids will say, I'll come back and see you. And if you pursue them, and I've had a couple of kids where we've had to contact them a couple of times, they eventually, they see that you care and that it's important, and you can get them to move to that next step. Next slide, please. And then finally, referring for treatment. It's important to summarize, once again, what your concerns are. Talk about the fact that you're going to be referring, and then invite the parents in to talk about it, because that's going to be a step where you're going to have to break confidentiality. Those aren't easy conversations, and certainly they're time-consuming conversations, but obviously these are the kids where you have to save their life, because tomorrow they might be overdosing. Next slide. Remember, it's important, the TSA to document what it is that you've done in the medical record, the tools that you've used, the scores that they've achieved, and any actions you've taken in terms of brief interventions, guidance, or referrals. Next slide, please. So remember, SBIRT is extremely effective. It's been shown to decrease the frequency and severity of drug and alcohol use, reduce the risk of trauma, and reduce risky behavior. It works. Next slide, please. These are some resources for folks. SBIRT Oregon has an excellent website. The wait21.org has a really fabulous video that I often use in education with my patients. It's sort of a cartoon fun thing, but it really explains a lot of what Dr. Williams was talking about with brain development and addiction and changes in the priority of hierarchy of needs for kids in sort of an entertaining mode that actually really kids respond to. And then finally, don't forget that SAMHSA has an excellent website, including a section on SBIRT. Next slide, please. Remember, payment for screening is possible. The codes that you would use are generally sort of the same ones that you'd use for developmental or behavioral screening, the 96110. Next slide, please. If you're just doing a full screen only without intervention, the code is 99420. If you're doing brief interventions that are greater than 15 minutes, you can use an additional code for higher reimbursement or payment, 99408. Greater than 30 minutes, 99409. And there are the corresponding Medicaid codes are there. Payment oftentimes will vary from state to state, and the AP does have resources for folks that are having trouble or need assistance with their coding and billing. Remember, prevention and early intervention can make a huge difference in the life of the teenagers in front of you. And next. I'd like to take the chance once again to thank the Conrad N. Hilton Foundation. Their support has really been amazing, both in the PIAASU project and also in making webinars like this available. And also the AP's practice improvement to address adolescent substance abuse project, which, as I said, Connecticut, Georgia, and Utah are parts of, and this is part of our way of sort of spreading the lessons that we've learned. Thanks, everyone. I'd like to open it now to questions.
All right, thank you both so much for that great presentation. We do have quite a few questions that came in, so I'm gonna go back to the beginning here, and I also want to let everyone know that is on the webinar that if we don't get to your question, I will make sure that the presenters do get your question, and we will get an answer to you after the time frame is over. Okay, so the first question that we had that came in is, does the physician provide the brief intervention, or does another staff member?
So that's a great question. In our office, our work routine is that the screen is handed out by a medical assistant, and then it's scored and documented by the medical provider. There are certainly, if you use some of the text that we have, there are practices that I know of that where non-medical providers, nurses, even MAs, and sometimes therapists provide the briefing. So it doesn't have to be a medical provider.
All right, thank you so much. And actually, it looks like that was the only one that had come in that we couldn't answer. There was another one that asked, what are some examples of the validated screening tools that Janet referenced?
So I would say the validated screening tools were listed by Robert, and it really is a determination in using a few brief questions, either those 3 pre-screening questions of the craft or the S2BI. Those are really the best ones for adolescents. And when we use the S2BI, we always add the C-CAR question that Robert said the behavioralist found essential. Partly because the person that they're riding with might be their parent, and we need to know that. That puts them at risk. It may not be the patient. So we find that it's really important to use a combination of those 2 screens, and we do not use the audit the DAST-A or any of the others, because if they're going to need more intensive assessment, they will probably go to a behavioral health provider at that point.
Okay, great. Thank you so much. Another question that we had is, to what extent is SBIRT used in public schools by counselors or social workers in middle school and high school?
I don't know the extent, but definitely SAMHSA and other funding agencies have been promoting the education of a very broad range of providers that include educators, social workers, psychologists, on and on, not just a physician. Like Robert mentioned, dentists, nurses, pharmacists, others. But in the schools, I know that there's been a big increase in university level interest and use of screening tools and SBIRT as an approach. So exactly how that quantitates, I'm not sure, but I know that regionally here in Texas, there are annual meetings that bring all the sort of peer group interested in peer student group interested in SBIRT and the counseling services together, and it's quite a large and broad representation. So I'm thinking that it's gaining momentum. In the elementary school, middle school, I'm not sure how much, but I would say anytime there's especially someone coming out of training who's a psychologist or a school nurse or social worker, they're going to be trained in SBIRT.
And I know.
Can I add to that really quickly?
Yes, absolutely.
Oh, great. This is Alexa from the Hilton Foundation. I know I heard Dr. Dudley chime in, so just quickly wanted to mention that we have been partnering with the School-Based Health Alliance to support utilization of the approaches in school-based health clinics, similar to other health settings. I think they have a range of practitioners that play different roles in terms of the screening and the intervention. So I'd encourage you to look at their website. And I know that, I don't know, Dr. Dudley, maybe you could speak to this a little bit more, that Massachusetts, I think, has a model that they have been really advancing, as does Wisconsin, that exists outside that separate structure of school health clinics and utilizes a range of different practitioners to do this work. So just wanted to add that as well.
Yes, I would second that. So we have 3 school-based health centers that are participating in our chapter initiative, and it does take, I think they've encountered slightly different experiences. They have integrated behavioral health literally sitting across the hall from them, so oftentimes getting that assessment from behavioral health is easier. Although if you have a moderate to severe substance use disorder, it really does involve a little bit more legwork to get the parents involved and get the kids into treatment and back into the medical home, sort of referrals to the medical home. So, but it's a wonderful thing to do, and I think can really be done by anyone. I was going to add also that in Connecticut, we've run programs for DCF workers, so they're very interested in screening both parents and teens, especially around substance use, and helping to get interventions made.
All right, thank you all so much. And at this time, we're actually going to close the questions period since it is a little bit after 2. I want to thank you all for your great questions, and thank you to the American Academy of Pediatrics, the Conrad and Hilton Foundation, and Dr. Dudley and Dr. Williams for such a great webinar. At this time, I would like to go over our evaluation and CEU instructions. You'll receive a few emails from us following this webinar. In these emails will be a link to the recording of the webinar, as well as a PDF version of Dr. Dudley and Dr. Williams' slides. Also included in the email is a link to the evaluation. Our grant evaluators are required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintain our funding and continuing to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for a certificate of attendance or a NADAC or PCB CEUs. Should you choose to skip the evaluation and proceed directly to the CEU request, leave all answers blank on the evaluation. Again, we want to thank you for your participation today, and if you have any questions, please feel free to email us at info@ireta.org. Thanks, everybody.